Please come to the round.
सिर्फ जीनत के लिए ही आ जाए।
15 minutes.
हम लोग भी वैसे ही
उसी के लिए आ रहे हैं। हाय।
ताकि खाली खाली नहीं।
Come. Just a small informal gathering now.
जो इतना
Why don't you all invite me?
Yeah, well, you sit over.
Nahin.
Yeah, of course. Okay.
We need her here. Hi everyone. I'm Hina Goswami and I'm doing my PhD thesis under the supervision of Professor Farhat Hassan. So that's why I got the opportunity to be part of this conference. I'm also married to the co-investigator. So when Mukhtar initially told me about this conference on health, and I thought that, maybe we could involve IGPP, the research think tank that I work for as an editorial consultant. And because we have been doing a lot of work around mental health and well-being, children's health. And so we thought maybe we two could come together, and we had this small window, open window at this point. So uh, we thought we would take this opportunity to introduce all of you to the kind of work we are doing, and maybe have like a larger discussion about health, mental health, and dementia, aging, and such aspects. I hand over the mic to now Dr. Manish Tiwari. He's the director of IGPP, and he has been such a pillar of force and strength throughout this conference. And thank you for being there and providing Mukhtar, me, and every one of us is grateful for your help.
आगे आ गई।
Yeah, that's better. Thank you, Hina.
Need to bring it closer.
Okay. Thank you, everyone, and Professor Gartner, Professor Farhat Hassan, Mukhtar, my colleague Hina, all of my colleagues here, all of the professors and invitees for the conference. I'm thankful for you for joining in this session. The idea about this session was that, the kind of work we had been engaged in, which is largely not much of academic research around health, but this has been more around kind of, impact assessment studies and some projects, advocacy projects we had done in the past around health. I am by training a sociologist and had worked around water for my PhD, and then been more into communication for last more than 2 decades almost. So I'm really happy for this. Thank you so much. Let me just quickly let you know about a few things which we have done in the recent past. We have worked on one of the primary things was front of package labeling. It was an advocacy project of this is Global Health Advocacy Incubator in Washington, D.C. And we had worked with the grass tops influencers in policy making in government to let them know about what kind of front of packaging labeling is required and whatever the scientific perspective of this. We also worked on the digital health innovation for COVID-19 response in India for an organization in Netherlands, which is called Terrace de Homes. And we had done an impact assessment of the efforts which they had took on the ground in training the A&M workers and all of them. Other than this, we had, for RTI International, we had worked around a study on 2 barriers to HPV vaccination in India. This was in Uttarakhand and in Bihar and West Bengal. And there was, for a GIZ, we did something around accelerating universal health coverage in India. This was 2023-24. So this is the kind of work we had worked on health as an organization. And aging and mental health is something which had been close to me as a research subject for certain reasons. And my colleague Tanushka, who happens to be my niece also, she had done her first MA in public policy at Kautilya and completed 23. There also, she had worked for her for her MA dissertation, landscaping the policy environment around dementia in India overall. And she has just finished her master's in health policy at Yale. And for last more than 1 year, she had been working with an organization where she has now got a job also, which is called Live Well. It's an institution for people with dementia who are living there, and then she is doing policy work and some other work with them. And her major focus for her master's is also this. And the idea is that we want to cultivate this whole policy area around aging and mental health for IGPP, and where we want to work around policy landscape, policy briefing, some advocacy, and research around it. Definitely not as deep academic research as all of you are working on the health particularly, but more on the policy and advocacy side. That is what our aim, and we are going to start in this thing maybe another month or so. We are thinking of taking this thing up. So now, because Tanushka had already worked on it, because for her master's doing her thesis, she had come across the historical aspect of this also. So she is going to make a small presentation about how the mental health has been seen in history and what kind of, what is its perception, how it was labeled, and all. This is it. Thank you so much.
Hi, good afternoon.
I just want to add that Tanushka is my student and she is at Yale, so that speaks a lot about me.
All right. I would want a quick screen share. Can I? All right. I have a very quick 5 to 7 minutes to share and tell you all about dementia. So,
First, introduce yourself.
all right. Good afternoon, everyone. I am Tanushka, and thank you for the introduction. Okay, I'm really honored to share this during the open forum because what I'm presenting today sits at the intersection of experience, history, and policy. And my talk explore how dementia has been seen, treated across centuries, and what that journey tells us about how we care or fail to care today, especially with the aging population. This conversation isn't just about medicine, it's about empathy, systems, and roles we play in shaping future health practices. All right. So, dementia, as we know it today, sound like a modern diagnosis, but actually, symptoms like memory loss, confusion, personality changes have been recognized for thousands of years. What changed over time is how societies have understood those symptoms, them or not treated them, and most importantly, how they have responded to people experience them. So let's begin.
Some things.
In ancient Greece and Rome, we already see mentions of what we call dementia. Hippocrates, Galen talked about the brain controlling memory and behavior, and they linked mental decline to aging and changes in body fluids like black bile. Then there was Cicero, a Roman philosopher who made a really progressive point. He believed that losing your mental sharpness in old age wasn't inevitable. He said that with the right habits and discipline, people could stay mentally strong, quite advanced for the time. But fast forward to medieval Europe, the things got more rigid. The church came into the play, dominated the thought, and symptoms of dementia were often explained through religion, seen as a punishment, demonic possession, or moral influence, even, or a failure. People with memory loss, confusion weren't treated methodically or medically. They were often cared for, if at all, by monasteries and almshouses. People with memory loss or confusion weren't given support from the state or real treatment, and the treatment what was provided was majorly isolation, neglect, or religion comfort. And then came enlightenment. Science started to challenge religion explanations. Doctors like Willis began to look at brain itself, and over time we see the first medical definition of dementia. Esquirol in France and later Praklin in Germany defined dementia as a condition where the brain slowly deteriorates over time, not just aging or madness, but as a disease. This was a turning point, but even with this recognition, treatment didn't improve much, and elders showing sign of dementia were placed in asylums, not to heal them, but manage them. These institutions were funded by the state, yes, partially, often, most of the time, no, but focused more on control than care. So, what were the solutions? Back then, they were mostly trial or error, herbs, bloodletting, diet changes, or spiritual rituals, of course. And primary goal wasn't to improve the quality of life, but just often to contain the symptoms of the person or the person itself. Now, today we have much better diagnosis. We have MRIs, PET scan, some medication that manage the symptoms here and there for a while. But here's the reality: we still don't have a cure. A huge number of people around the world don't even have access to basic diagnosis or care for dementia. So yes, medicine has moved forward, but if we zoom out, the bigger question is, have our systems and responses have really evolved enough to support that? Social responsibility. This is where I want to shift the focus a bit because dementia isn't just a medical issue. It's a deeply social one. There's still so much stigma around it. People hide diagnosis, families stay silent, and patients are often isolated in the case. And who's carrying the weight are the family caregivers, most often women, often unpaid, doing emotional labor day and night, and with very little recognition or support. So we have a huge responsibility here, not just to recognize dementia as a condition, but to see the people evolve, and build a world that supports them. What do we need? So where do we go from now? From here, first we need to talk about dementia openly. The more we talk, the less stigma here it is. Second, we have to make dementia training universal. The nurses, the doctors, the police officer, the first responders, even the bus drivers for that sake. Third, we have to support the social caregivers, not just the words, but in respite, financial help, mental health support, very important. And we need to reimagine our communities, dementia-friendly housing, transportation, services, workplaces, communities. Dementia in itself, it's growing and it's affecting us all. The question is whether we have the science, so we have the science, but we have the will to respond with compassion, equity, responsibility, which don't come instantly with medical profession. Here are some tools, data, and resources. There are very much handful of them, very few of all that we have. But before I close up this quickly, I just want to zoom out and look at the global policy landscape and how it is responding to dementia. And right now we have over 55 million people living with dementia worldwide, and that number is expected to double by 2050. Mostly in low and middle income countries, with more people living beyond 60, the burden on families, healthcare system, and government is rising fast. The World Health Organization has recognized dementia as a public health priority. They have urged all member states to create national dementia plans. Some have not, but there are only about 40 countries who have done so far. Some countries are leading the way. UK has launched Dementia Friends campaign and national strategies. Japan created local dementia supporter program and community, looking at its population size and increasing. Germany and Australia have focused on long-term care insurance and community care, but many countries still lack the basics, the infrastructure, the funding, and the political will to act, which actually execute the social policies in action. Even in countries' policies, implementations often fall short. So globally, we are recognizing dementia more clearly, but the system of care and support haven't caught up with the scale of the challenge. Thank you. I'm open to observation, follow-up, and questions. Stop sharing here.
Huh?
Okay.
Well, thanks for a very crisp note. But I wonder, is forgetfulness that bad? I'm only 74, 75, I'm turning this year. And I love to forget. It relieves me. I'm happy about it. My wife complains. She says, like madness, it is very selective. You have selective dementia, forgetfulness. What you want to forget, you forget. But which I don't want to forget, oh, no problem. So is it really a medical condition? I personally feel it's a step towards growth. I'm growing. I'm growing as ever, as earlier. And it goes. So I don't know, in some cases it might be nuisance or required medical attention, etc. But we can manage. An individual himself can manage. And of course your data, etc. it gives you. And most of the time I find this illness more in the West than here. I had my older people, predecessors who are no more. They complained of forgetfulness, but they didn't take it as illness. They said, finally, yaar, bhul gaye. And this can be a very good excuse for not doing many things. Thank you.
So,
Tanushka?
Yes.
Did you hear me?
I did hear you, sir. And I think we in the East are really fortunate to what you mentioned briefly, like I have my people. I think we are really lucky that we have people and neighbors and families. And I think that's not the case with where I am sitting right now, at least. So I do take your word for that, yes. And it is kind of a like blessing in a hindsight. But I think still we should do something about it. For
no, what you no, no, so what you are saying is more of a philosophical level, which is like we are growing and we are going out of this whole thing. But if you look at this whole situation, particularly, there are people like, we have reported cases where what families do that, they take their elderly or anybody who has forgot, they take them and then they drop in some other city without any sense and they can't go back.
It's a crime.
And it's a crime against them. And the problem is that this whole disease, which is actually a disease, is there is no recognition in terms of like now medical science is recognizing it, but even then there is no place. And the way our society is growing, particularly, we are going like you are fortunate to have people or maybe your children, then it is still okay. But people who do not have, or people like, this is one of the major issues these days which is happening. Like we had been noting down in kind of working around these things particularly. So even if you have dementia and you don't know what to do, what to eat, what to not, where to live, what to do in such a situation, what somebody
You
would
need
do.
support.
There is no institution as hospital, no hospital, however rich you are, will take you in as a patient. Where would you go? There are no facilities for these things. And that's a larger policy gap we see. Look at this.
Also about care, like we think we have support because we in India we may be part of joint family. Not that I know a lot about it, but from briefly what I've seen around, it's asking a lot of the people around you as well. And it's a baggage on their life. You're taking, like, a large part of their life is dedicated to your physical safety. How do they go on their lives? So it's I mean, we are taking that support for granted, but we are taking something from their life that we won't be able to return.
Um, Kanishka, thank you very much for selecting this problem. I am Professor Ashar Qadir, belongs to the Unani Medical College.
Yes, sir.
And being a medical person, I know that medical science doesn't ignore any ailment. So in Unani system of medicine, you have mentioned about the resources in our, that is Hippocrates and Galen. Those are our elders, and this type of dementia has been described in our text by the name of Nisyan. This is Arabic term Nisyan. Nisyan. And the melancholic, it is means that is the humors, and which is termed as Sauda.
Mhm.
And when it becomes pathogenic, it is known as melancholia or melancholic, which refers to the melancholic melancholia.
Yeah.
So there are these problems is associated with the nervous system, in particular brain and the nerves.
Yeah.
And by virtue of Unani system of medicine, the temperament of brain and nerves are cold and wet. Cold and wet.
Mhm.
And everybody, when becomes old, automatically the temperament changes from hot and cold or hot and dry. Everybody temperament changes towards the dryness and coldness. Towards
Yeah.
the dryness and coldness. मिजाज बदलता है. So it may be divided into three. So in the modern terms, there are three types of terms available. Number one is Parkinson's disease. This is also a matter of the nerves. The second one is dementia. It is very common. And the another one is Alzheimer's. These are the diseases in the modern. But the dementia or Nisyan, that is the condition where everyone have to go, because our life process have there the four stages. Number one, adolescent. The second one is the adulthood, and the last being the decline and the old age. So it occurs normally or begin to occur about 70 years. No. About 70 years. About no. Mostly about 8 years, but it occurs. What do you mean by the occurrence? When things are noticeable on the basis of the symptoms, when a thing comes on the radar of the physician. That is why I am saying this. So, number two, we have assigned it. There are two types of problems. Number one, non-communicable and is communicable. So it comes under non-communicable. When it comes under non-communicable, so there are some things. For number one is diet, locality, faith, work, profession, etc., etc. One thing is very important, that you will not find this thing similar to everyone, because in normal circumstances, in Unani system of medicine, which belongs to the Hippocrates and Galen, we have classified the person into four categories. Number one, hot and dry, hot and wet, cold and dry, and cold and wet in normal situations. So when a person is already cold and dry, it will be more severe, affected by this disease. And when a person is cold and wet or hot and dry, that will take the least symptoms. So as per the sign and symptoms are concerned, we have to very particular about each and every patient. I am using the term of patient because it is a type of handicap. See, for example, okay, somebody is not able to even utter or recognized the attendant, the familiarity. So it will be a very crucial problem. Even then somebody is eating, okay, so he is not able to pick up the food and recognize the where is the mouth. So it is a problem of dementia. So in the last, in short, if you want to collaborate, so we have our institutions, our departments, our experts with you, and you can cooperate, no, collaborate to us, and I am always with you to solve this type of problems. Our literature is very rich, and there are 14 departments, and every departments have the experts. So this problem, or I am very true that this problem may not be only be um, managed, not cured. Okay, it is a normal, natural morphological problem. Normal, natural, morphological problem. Because pathology is also a natural thing. If somebody is hiccup, if somebody is, that is a natural thing. Okay. So how can we uh, cure ourselves and delay not only the dementia, but the old age? That will be beneficial. Two things are certain: old age and death. The physician is only there to delay them, to make a person perfect up to the last breath. Thank you.
Any other question?
So it's not more of a question, but it's a very sensitive issue that we are discussing right now. And I'm sure that some of the people sitting here, they have old and elderly parents. So say, for instance, my father is in his late 70s, and throughout his life, he's worked very hard, obviously. And so now, as his old age is approaching, he must be 76, 75, 76. So we often play mind games with him. I engage him in Sudoku, for example. There is Pelmanism and things like that. And of course, as far as maintaining a very healthy regimen is concerned, he does that on his own. So he goes for morning walks, late evening walks, and then he takes fruits and everything, like proper diets he takes. So, I also wanted to know that what are some of the things that we can do with our parents, or, anyone who's turning old or more than 70 years before this routinely medication starts in. So is there something like, will these mind games be able to delay this process of dementia? Because as Sir pointed out, there's no way that we can stop this. But then there are people, like, I've seen people in my family, probably they belong to an earlier generation, and so that's why they were lucky. So they did not have any streak of dementia in them. And, they passed away very happily, when they were in their 90s or things like that. But probably because that time air, water, and food, it was much purer in comparison to the kinds of things that we are consuming now. Because it's a real fear, and one keeps on reading these newspapers that, suddenly a mother wakes up and she can't sort of, recognize her own child. So, that's a really traumatic experience for the entire family. So, are there certain practices which we can do with our parents on a daily basis so that this can be delayed at least?
Okay.
Just a question. Okay. Just a,
I
are,
think
are, you- are your
the-
father has been diagnosed? So don't worry.
That is it.
Until and unless somebody has not been diagnosed, no, nothing else.
After listening to Sir now,
No, that is a normal problem.
so I get a feeling that probably he has also developed selective.
No. One minute, sir. 1 minute, sir. Dementia is a general problem. If
Tanushka?
somebody, 1 minute, if somebody, okay. If somebody is suffering from the auditory nerve only, so it doesn't mean that he is suffering from dementia. Okay.
Tanushka?
all right.
Hello, this is
Would like to highlight very quickly there are 14 modifiable risk factors for dementia that have been identified in 2024, which includes limited education, hearing loss, high blood pressure, smoking, obesity, depression, physical inactivity, diabetes, excessive alcohol consumption, low social contact, and such things, which actually should be checked as the person moves above the age of 50, and they should be kept in check throughout their lifetime. That is one way to know. And thank you for sharing that. It really brings us back to the emotional heart of this issue. So, what you're doing, engaging your father in mind games like Sudoku or encouraging daily walks and everything, is exactly kind of preventing care that we are talking about. while we can guarantee dementia won't occur with these activities, these activities have actually shown to help maintain cognitive function, and that may actually delay the progression. Mental stimulation, physical activity, social interaction, and balanced nutrition are the key to the pillars of brain health, and all sort of medical field of study support that. These are the basics to start with. And you're also right that earlier generations may have had different exposure, cleaner environment, less processed food, which may have influenced overall health outcomes, which may have. And you're absolutely right. When memory loss reaches the point of not recognizing the loved ones, it's deeply traumatic. So not just to the person, but for the whole family. So to answer your question simply, yes, these daily meaningful routines do matter. They may not be a cure, but they may help protect what's there, uh, and nurture connection and offer quality life. And I'm talking of quality of life overall, because the modifiable risk factors and how to get over it actually includes the entire lifestyle change, and that in itself is an incredibly powerful. Thank you.
Thank you.
I'm Saeed, Dr. Saeed from Ministry of Ayush. There my only one submission that if you want to know about dementia or forgetfulness in Unani medicine, there's a very wonderful book recently published by Routledge, edited by the great boss Ibn al-Jazzar's book on forgetfulness, yeah, Maqala fil Nisyan by Ibn al-Jazzar. Ibn al-Jazzar was a physician of 11th century, Algerian physician. Now it is available in Hebrew, edited with English and Hebrew, with Hebrew and Arabic text. So if you want to know something about Unani medicine in terms of dementia, go through. You will find a lot more about recommendation, dietary managements, and therapeutic management, as well as early prediction of the dementia. What type of the temperament may occur in late age in dementia. Another book was Makala fil Malikulia. It was not translated in English, but earlier book was very good. Want to consult? Yeah.
So just a few scattered points. Thank you very much. And thank you for organizing this, taking this entire conference in a good way outside of its comfort zone, but allows us to actually raise a few questions and make some observations across space and time that I think maybe I'm being naive, and it's a question I actually want to pose to you eventually is what is the role of history or of, let's say, medical humanities in general in facilitating the work of organizations like this and in policy in general? I think it's a question that is being asked around the world and answered in very different ways. But I just wanted to make a couple of observations from a kind of a long-term historical perspective, which I'm sure won't surprise most historians around the room. But again, we're having an exchange. So first of all, apropos of reading recommendations, I think closer to my period of expertise, there's of course a very famous book by Petrarch on senility. So I think it's the most profound and most famous exploration of old age in a period in which if you lived above 45 or 50, you are old. Just statistically, the life expectancy is, around 45, regardless of what you do. If you remember from Giovanna Bianchi's presentation yesterday, we are very proud, as it were, to say that our miners, so remember, manual miners living to the age that was the average of the general population, urban monasteries, was 40, 45. So these people lived to the ripe old age sometimes, and women sometimes scratched 60. That was the thing. So in that sense, it's as a reminder that old age is also a statistical and relative and situated term. Sure, some things might not happen to a healthy body at the age of 45 that would happen to a healthy body naturally and normally at the age of 70 or 80. That's undisputed. But the perception of someone who is in need, has different needs or different or less capacities could change across those years. I also think that you make a very important point and this is something that historians of health and medicine have observed, we have, first of all, it is a society, it is, you know, zooming out of the suffering of individuals who might be on the kind of in a liminal state where they might, and I've seen this with my own grandfather, who think they should recognize you but don't, and that must be extremely painful. I hope no one experiences it, but it must be extremely painful. In that sense, it is a problem. It is, they are suffering. But if we zoom out from that suffering, the things that you point out, and you pointed out, that it is a societal problem, and it is a societal problem in different ways, in different contexts. I'm no expert on India. I'm no expert on many other places, but clearly in Western society, the concept that we need to outsource everything to institutions, to experts, and so on, so that we can earn enough money to actually fund those institutions is a problem since the Industrial Revolution, because we need to work all the time. Men, women, children, right? Otherwise, we don't have money to support it. So undoing it, or what we are beginning to call, if you'll excuse my French, degrowth, right? Just to take it easy for a little while and say, well, maybe family does matter, or maybe community does matter. And the answer to these questions, sure, in part they're in the medical sciences, but at the end of the day, no one stops time. So what can we do? We can intervene in society. What are our values? What are our goals? How do we live? How do we, you know, what do we prioritize? And in an ironic way, dementia would not be a problem if it weren't impacting society. We let a lot of people suffer every day, all day. But until it doesn't, and it doesn't make us bad people. We are just trying to live our lives. If we very few people have the capacity to tune in to other people's suffering to the degree that they will be able to address it directly all the time. Our minds are just not, our hearts are not built to do that. But there are easier things to do in terms of social medicine, public health, prioritizing institutions. Like if we had hospices or hostels, if everyone had universal access to those kinds of things, you wouldn't have to work 3 jobs to fund your mother's home that you could never visit because you're working all the time to afford it. That's the cycle we're in, at least in many countries. So the solution, the problem starts in society and it's got to end in society, if you see what I mean. And really, the final thing I wanted to add is kind of turn it back to you or anyone involved in the think tank, is really what do you think history, or again, the humanities more generally, whether it's philosophy, history of science, and other kind of traditional fields, what is the kind of dialogue that you envisage? What do you think it is necessary for? What does it help that we have an accurate description of the evolution of a concept of aging, for example? I'm curious as to your thoughts.
I think to answer this last part of your question, what I believe is like, because we are in a state where we all are like at a situation where we live in a state, a state which prouds itself as welfare state. And when it is welfare state, whose responsibility it is? I do have limitations as an individual to make institutions or things for my own self. I have limits of resources and I have limits of the legal binding of the constitution I live by. Now, in such a situation, what the state is doing, because what a state is doing is very important to know, because what your priorities are. So what Japan is facing today, we might face after 50 years. Now, are we prepared for it? That is the first question. Now, before we are thinking, we started as a country, India as a country started with population control programs. And now we are into a situation where, it is getting stabilized. Now we are moving towards something else. Now here comes history, that what exactly historical idea of this whole disease is. Because who is deciding for us what should be the focus? So we have spent a lot of resources on something like AIDS control, something like preventive health, maybe HPV vaccine and everything. But was it as required or it was somebody else's agenda? Now, here comes history, which can tell us that no, this is something which has been part of it. It has been recognized, it has been identified, and this is something you should prioritize. And that is where I believe that the role of history and research comes into policy making particularly. That is where I feel like, as an institutions, we want to collaborate around its research and put it a solid, because as a solid basis to advocate for a policy, because right now nobody's doing it. Even after the global mandates, we have not made a policy towards dementia. No state in India has it. And for something like, we have called as old age homes, they don't have any care for it, not even the hospitals. So, like, to me, it looks like sometimes a very, very selfish problem, because my, the earlier generation has maybe 5, 4, 6 children. This generation has maybe 2 or none. Now, where would they go? I know people who have got dementia and they don't have anybody to care for, or maybe one child and the child is not living here. Now, what is the eventuality? That is a big question for a society of to us. So that's where I look at the role of history and for the policy making particularly.
Um,
बोल ये ले लो।
नहीं, नहीं, मिल जाएगा। Thank you. This has been a really, till now, it has been a very enlightening session on an issue that I think affects it's across class lines. It is not limited to one section of the society. But I was just wondering about two things. I mean, one is about the trust. I mean, when a person is suffering from dementia or Alzheimer's, there's also an issue of trust. For instance, even if he or she recognizes the family member, it doesn't mean that they will be trusting you. And there has been cases which in my own family, extended family, where they get this idea that there is water and in it there's a pin. And they will repeatedly say this, that there is pin, you have to go and empty it, bring it again, bring it again. So that issue of trust is there. There's nothing to do with, I mean, in that case, recognition of the loved one takes a back seat, even though the person is recognized. And the second thing that I was just wondering was that is it only the family members that we are this thing? What about friends? In the sense you have long associations with people who we have worked with and suddenly you forget about them. But there is an interesting case that I would like to highlight is about Dilip Kumar, who actually was suffering from acute dementia. An interesting thing is that even though he didn't recognize his own wife, Saira Bano, he recognized Vajanti Mala. And Vajanti Mala, he used to talk a lot to her. So that is something that I wanted to bring to light, that it's not just about forgetfulness. Even in an extreme case of dementia, there are episodes, there are people that you recognize and can and recall your days with her or him.
if you permit, sir, I take only 2 minutes. वो पंडित नेहरू भी बहुत पसंद करते थे ये, और हम यही कहेंगे अपने दोस्तों को जो हमारी तरह जवान हैं कि वो हाफिज जलंधरी का बहुत खूबसूरत गजल है। Oh, that I would do. What I do. Listen to that song. Pandit Nehru loved it. It says, I'm still young. I'm happy. Air, the entire atmosphere, very good flowers, blooms, around you, lots of songs all around. इधर तो of course atmosphere is always young. No, Vasant hai. If you feel Vasant, it will come. इधर तो आ सुबह उठा प्याला भर, सवाल है प्याला भरने का, आप प्याला खाली रखते हैं तो मुश्किल होती है। तो थैंक यू वेरी मच। मैं नहीं, आप, ये मेरा बहुत फेवरेट सॉन्ग है, और ये नहीं, मैं जवान था तब भी सुनता था रिकॉर्ड पे, और अब तो बहुत सुनता हूँ, क्योंकि आई लाइक इट सो मच because there is a whole falsafa, and you rightly said it's a question of philosophy. You know, family has broken down, I understand. Not everybody is lucky to have a pension like me. There is no money. I'm lucky to have, I know the pain of my own cousins and many others who live in the villages. They are left out. They are left out. But it's a huge societal problem. And one thing which I'm very happy that you are at least conscious about it. And what we need is to rouse societal consciousness. That please think over. Sometimes your own son gets tired of you and then leaves you. Your own flesh, your own body gets so tired of serving you that he wants to sorry about. Thank you. I have the money I can buy healthcare. 1% of the population, 99 doesn't have. So and the government can't do much because of the accountability and so on, the expense involved. Government will say, "Oh, thank you very much. It's an act of God." I mean, in 4 years ago, we saw, and it will give a huge minimum statistics that there's only 3 lakh. मरे 30 लाख, तो वो करते हैं। So, but consciousness at the school, I believe at the school level, school level, it should be taught as part of the social science program. Dementia should be included. That, look after your grandparents. Grandparents are at a loss in this society. In 21st century, it is not parents, but grandparents have lost a great deal. Because everybody has migrated elsewhere, many places. So we need to talk to at the school level, and I think it will remain. If the seed is sown at the school level, and then coming generation would look after, would be careful. One can do only up to a point, because sometimes body degenerates to such a level that everybody is fed up. Even doctor is fed up. What can you do? But so long as it can be managed, what matters most is friendship, is their own club. In the housing societies, encourage to have their own club. Most of the housing societies, they don't have a library, small library. They should have a small library where senior people, younger can come. Have a small library.
Better concept.
It's as important as a dispensary in the neighborhood, so that he can read, he can engage himself. And there is so much to read, so much to do in life, that with my personal year, I don't feel really that I'm turning 75 this year. Only next month. I mean, there is no way I can feel. And I tell you, forgetfulness is selective. If I want to remember, no one can stop me. If I want to do something, it will be done. It will be done. But if I don't want, that's another thing. So we have to raise that consciousness. Now, everybody cannot be as strong as probably I'm trying to portray myself. I know I'm weak at certain points. लेकिन ये होता. दूसरी चीज, make more family events. As you said, if mother is alive, and if they are turning 50th year of their marriage, allow them to marry again. वो marriage का एक फिर से function करो बड़ा. कर करके दोनों को, मेरी तो ख्वाहिश है शादी करने की, मियाँ कोई ना मिले अलग बात है, लेकिन उनको बिठा करके उनको माला पहनाओ. Make them feel that 50 years have gone by, they were wonderful years. You produced so much. Another thing which I am very beholden to my own daughter, that I play with my Nati Babu. I live in Hyderabad, I have left Delhi, and I don't have an iota of remorse leaving Delhi. 48 साल यहाँ रहा, आराम से चला गया. क्यों? क्योंकि there I have a kid. That 6-year-old keeps me. I can find my own reflection in him. डिमेंशिया का चांस ही नहीं है. तो आप लोग चक्कर क्या है कि आप ग्रैंड पेरेंट्स को बच्चे ही नहीं देते पेरेंट्स को बेबी दो. दिस व्हाट ही वांट्स. आप खुद ही बेबी बने हुए हैं. ये नहीं चलेगा. थैंक यू. ये नहीं चलेगा. आप अगर पेरेंट्स को अच्छा देखना चाहते हैं, अगला जनरेशन उसके सामने रखोगे तब ना खुश होगा.
But then
How
that
will he
is
be happy?
asking
Sorry to say.
thing
Sorry,
of,
sir. I moved to my mother tongue, which was it was just a little emotional issue. Sorry.
Just one minor thing, nothing more than this, since we are on the topic of dementia, selective forgetfulness, and all. I think one of the worst things that I have seen is about death. And what I mean is that, for instance, there is a sibling, and the elder sibling is around 90, 92, or suffering from dementia or Alzheimer's, and the younger sister dies. And they don't know. There's no and family members are hesitant to tell him or her. And he thinks that her sister is alive. And he talks as if कि बहुत दिनों से फोन नहीं आया उनका, and कहाँ कर रही है, क्या कर रही है. So how can you convey that to a person who's suffering from something like Alzheimer, that if a person, a sibling, not even a friend, a sibling passes away before the younger sibling passes away before the elder one. I think that's one of the worst things, that not just to family members, but also for the person who is suffering from that kind of thing.
Yeah.
आपसे गुजारिश थी कि आपने जो ये नज़म पेश की थी उसकी मुल्का फकरात ने जिसको बार बार गाया उसमें वादे अलस्तो का जो था अगर उससे भी तौजीह कर देते.
Okay, can we
Yeah.
try to speak
In English, please. Yeah.
In English, please.
Joyita, we'll take one last comment or question from you,
Yeah,
and
this
we'll
should
wrap
be
this up.
done.
Yeah.
Is this comment? I just wanted to, this is, well, I just wanted to return to the question of what is it that the past can give us when it comes to thinking through these things. And this comes from a person who works very far away, very deep into the past. I think it tells us that a lot of the rubbish we come up with are just excuses. If you have excellent evidence of caregiving in the past, when resources are scarce, when the death rate is through the roof, then there shouldn't be, it should destabilize the sort of excuses we make in the present when it comes to caregiving, to ideas of letting go, as well as ideas of compassion. So I think that's where the value of the past lies. It gets rid of our sense of surety, and also the fact that things supposedly get better with time. It destabilizes that. So I think that's where historians can contribute.
Thank you so much. Now we,
Should we just transition?
yeah,
Yes, we are.
now we simply transition.
Perfect.
You please now take the
Take that mic and we can.
main seat.
Yeah.
Great.
Phone. Yeah.
Okay.
Right.
We thank you very much again. Actually, I do have one last thought, and it really connects with what Dr. Pallet was just saying about the past. Also, one of its uses, one of its sometimes only uses, is to inspire us to not accept the present as a matter of course. Sorry to be banal, but I mean, obviously, that's one of the things in times, and I suppose, you know, this week was as worse as any to think about how things can be different. And we have to not just change or evolve. As we do, we can look at other examples that might be not on the table right now for various reasons because of political, economic, social, cultural, religious configurations. But at the end of the day, the family itself, certainly the nuclear family, is a very recent invention. And I'm talking about at least Western societies, global North, or whatever you want to call it. There's no reason why we couldn't evolve, given that our age, that our demographic profile changed so radically in the last 200 years, that people of a certain age and with certain capacities wouldn't be able to adopt different ways of life. Not only remarry or repartner or reorient, but also living in communities that are, you know, not marginalized and not stigmatized because of their age. I mean, we have wonderful examples of people living a full emotional life until a very late age, and they don't necessarily want to share that life with their children who want them to. We've heard all week about the rewards of babysitting. Maybe it's not for everyone. You know, maybe some people want to live their own life with their peers and travel and do things and cook and have fun. But in other words, I think that the construct of the family, or the construct of what the community of care should be, and we heard a lot about community of care, is something that can inspire us to think outside our box, because we all live in boxes, whether we like it or not. And it's emotionally very difficult, and logistically and financially very difficult to get out of them. But sometimes a little bit of inspiration and solidarity could help. And
Right. Before
please.
we move to the next session, I just want to thank Tanushka for joining us.
Yes.
And this session turned out to be very touching and emotive. Thank you. Thank you for joining us.
Thank you so much for inviting me. Save.
She can also join us.
Absolutely.
Just woke up and went to sleep.
Okay, go to sleep. Good night.
Thank you
Your teacher allows you. Okay.
so much.
Okay, I want to switch gears to basically make some concluding remarks, raise some concluding questions. Obviously, this is a line in the sand. We've all been having conversations for some of us for many decades, some of us from the last 3 days. It doesn't matter. It's a moving train, and whenever you get on, whenever you get off, it's your choice. So I'm just here to kind of take a snapshot of a few of the ideas or even provocations, friendly provocations that have come up. These are my impressions. They are not meant to capture everything and anything, so please don't feel like I'm drawing a mainstream here. These are really just my thoughts. I would like to begin by returning. So if you remember in my original presentation, I mentioned our previous the project on which this project builds, and in certain ways on which this conference is built. There is a rail to it. You may be uninterested in it at all, but the rail, and at the concluding conference of the previous project, we tried to sort of come up with, you know, what is that's holding it together, and that was also in anticipation of publishing that those conference proceedings. So we actually asked people in advance to be to think about 3 things at the same time, or to find the Venn diagram, or to aim their papers at the Venn diagram where the 3 P's meet. And by, sorry, no, it's not yet dementia, but just, you know, myopia. So the three P's, and I'm going to critique them because I'm moving beyond them, which is a good sign, I hope. The 3 P's were public, preventative, and practical. So public as opposed to individual or private, which I now think about really, because where do you draw the line between me and you or everyone else? So I'm more and more inclined after a few years of doing this to not talk about public or even communal, but to talk about environment. Because when you intervene in the environment or refrain from, so then the implications on everyone, they're not equal, but at least it's not just aimed at yourself. It's not a medication that you take, even though taking medication or not taking medication impacts your environment as well. But public, preventative as opposed to curative. But again, as we've heard time and time again in the presentations, where is that line between prevention and cure? And again, I think Dr. Paul's paper reminded us, care. Most of the time, it's care. And again, where is the line between care and cure? Where's the line between care and prevention? All of those things are a moving thing. So yes, there is like center and periphery to each one, but at the end of the day, it's very, very difficult. And literally, acts of cure are in themselves preventative. You know, as my recent visit to the dentist reminded me. But where maybe it's slightly easier, and by slight I really mean it small s, is practical, again, in opposition to theoretical or policy. And it brings to mind some of the discussions. Almost every panel we asked, okay, this is in a text, what is happening in reality, right? Also because many of the texts that that were discussed were theoretical texts. Preventative health regimens, medical treatises, this and that. And we almost, whether it was you or me or someone else in the audience, asked, okay, where is the social practice? So that's where we were sort of aiming at as a project, as a group of people thinking about public health, not because it's more important. Again, all of the oppositions, as it were, on these binaries are equally important. And at the end of the day, you do where your heart is and where your passion is. We're just asking a few questions that have, whether it's for the subcontinent or around the world, haven't been asked nearly as much as those other questions. Because if you know anything about the history of medicine, and we have some amazing experts here, really cure and theory and individual have been the focus historically. In the historiography, that's where most stuff happens. The public doesn't matter, non-elites don't matter as much. And practical things, especially for the period known as the Middle Ages or pre-modernity or the pre-industrial era, didn't matter. Why? Because, back to Farhat's because nobody really thought that public health was a thing before microscope states, representative democracies, you name it, germ theory, etc. So we're trying to rebalance, if you'll excuse my humoral reference, we're trying to rebalance the state of the historiography, and rebalance it not only in terms of these questions, but also chronologically and geographically. And so so as what I'm offering, these 3 Ps or three Ps with their asterisks, is in musical terms, just to create a baseline, just to listen to what's going on in that sense, not because it's more important, but because it's not been done yet, or hasn't been done nearly as much as the other things. And so we can orient our thoughts, whatever we do, and many of you have done that very successfully, orient whatever you were already actively doing or arm wrestled into doing by Farhat to contribute to that kind of debate. And I thank you for it. And I think it's been a very enriching experience for me, and I hope for my colleagues in Melbourne and elsewhere. What it does, and I've already touched on some of these things, and I think that it was very nice because Professor Kumar really set the agenda in that respect, because I think that every single panel, whether you realize it or not, probably you do, was you provoked in a friendly way a response from each panel. Almost from each paper, people had something to say very much in response to what you laid out in a kind of on a broad canvas. So thank you for that. That was extremely productive. And beyond the honor of having you with us, it's not just the honor. You actually stimulated a lot of thinking. And I appreciate it. So I just want to throw out, as we continue to move forward and before we open this up to discussion, just a few of the binaries that our project is actively, or at least if not passively, trying to complicate. And one of them goes directly to what we just discussed. Where are the boundaries between physical and mental health, including emotional health and emotional stability? Clearly, Galenism, Unani, humoral theory also recognize those issues. And again, historically, the emphasis has not been on mental health. So that's something we actually really need to think about, especially when we come to history of emotions and emotional history. I mentioned already the tripartite sort of care, cure, prevention. What happens with long-term trauma? And I really liked your idea of caring for the person or the soul or the individual beyond life as we know it. Very interesting example. We don't really think about it. It's unique to certain cultures, but I think it's in Christianity, it will be outsourced to the people who pray for the well-being of your soul. There are other cultures where they really fill up your jars every now and then to make your journey easier. I think those are things that are really fascinating to think about. I haven't so far, and I am grateful for that opportunity. The urban-rural divide, we didn't talk about it too much, but it's obvious. It's obviously there. We talked a lot about formal versus informal medication. What is tacit knowledge? What is explicit knowledge? What is professional knowledge? What is lay knowledge? Those are all things that I think history of science, history of medicine is really trying to is very busy complicating today. I was thinking during one of the papers today, when we talk about quarantine or travel bans, which we've all experienced, think about that apparatus and what does it mean for medical literacy? If we wanted to cross a border or enter an institution in COVID, we had an app. So we outsourced that knowledge to some gizmo. But in the pre-modern period or before digitization, think about the soldier that stands at the gate of the city or at the border, at the boundary of the countryside of the country, national or not necessarily, of the Delhi Sultanate, and on the road, and needs to stop or allow people to enter into this territory. And it's a time of pandemic, or even if it's not, they need to identify someone who has certain symptoms or not. Again, depending on the feel of how does that person know? What kind of health literacy does a soldier, sometimes a very simple soldier or guard, have to acquire informally or during their training in order to identify, to address these problems? That's not something that people talk about almost at all. In Europe, at a certain point, we have health passports, which again, outsource to health boards, and they say, you don't have the symptoms of smallpox, you may pass. I need to also acknowledge it as the soldier on the other side of those are things we don't talk about, these very low tech, and at the lowest level of society, what kind of public health intervention that is, and what kind of medical or humoral or whatever you want to call it, literacy that requires. And that's something I would really love to know more about. We mentioned the human-animal divide quite a few times, if you remember. People coming up from veterinary science into human health and vice versa. What do we learn across these two fields? I think it's fantastic. I'm no expert, but there is an entire literature that I'd love to know more about called Fugusia, which is basically about horse veterinary specifically, that's related to army and military exercise. And there's clearly a lot of knowledge about how horses, not just how to ride them and how to maintain their health, but how that spills over into community health when that community is the military community. And last point is this important, and it relates to that soldier I was talking about. How important is basically being able to make certain forensic observations? Who does that? Remember, most of us, 9 times out of 10, we don't get diagnosed by a doctor. It goes back to your point. If it's not diagnosed, it's not a problem. Well, it's often diagnosed, but at a lay level. We ask our mother, we ask our sibling, we ask our friends in school, oh, does this look, we do it ourselves, does this look bad? Should I go to the doctor? Oh, it's just a flesh wound. It will, that arrow will fall out of its own. So those are the kinds of things that, again, back to this issue of health literacy and forensic observations that we see that we could pursue on a path to understanding what health could have or did look like in earlier societies outside the sometimes rarefied air of university or academically trained physicians or very, very wealthy households, and the relation between that kind of center of knowledge and other forms of knowledges that are evolving. Okay, so those are all productive binaries or axes along which we can continue the conversation. I just throw it out there. you're under zero pressure to respond to any of these. You may have other irons in the fire, and yeah, I'm opening the floor to observations and questions and comments. So please use the microphones next to you, or there's a wandering mic if you need one. Questions on Zoom are, of course, welcome and will be observed too.
Can I?
Of course.
So, uh, I don't like to ask questions because it tells people how little I know of things. But throughout, like at many points in the 3 days, there was talk about that. Oh, what were the common people doing, or what were the the text that we are talking about relates to nobility or the elites. Uh, I do know that Mukhtar and Professor Hassan are dealing with groups who are traveling groups like pilgrims and soldiers. And when we say, oh, the text would cater to only an elite audience who would have the literacy, right? But we also know that that was not the texts were read in public. Texts were read for the knowledge of even those who did not understand the language. How would we define such groups such as merchants, soldiers, whose health was a concern, was taken care of text, and would not be cannot be considered elites, but their health was a priority? So wouldn't that complicate the question of, oh, let us look at at the lower strata, but they are already being looked at. Their health is already a matter of welfare. Uh, I don't know if that was a question or what. But yeah.
Should we just go around and raise? Yeah, I think this practice in the last few panels was very productive. That we just raise questions or make observations that some people I know are very new to this field or to these questions. Just there's no.
I had one point and then two questions. So, one of the places where I'm too scared to make the argument, but I'm hoping the methods develop someday, is when we look at injuries on the skeleton, we never consider if they could be self-inflicted, right? It's always a great idea to think of war and violence and those sorts of things, but mental health and issues and therefore self-harm is not something we've thought of. And I'm hoping that with better forensic understanding, we'd probably be able to get knife angles, axe angles, and perhaps then think of self-inflicting. It might be, I don't really know. I had two questions to ask the organizers. So the first one being that when I think of the word preventative to begin with, it sort of stands to me as something that is very related to contemporary death defying culture, the contemporary focus on longevity. So, would I be able to think of preventative in Buddhist texts, for example, is something that, I just wanted to know where, since you are pre modern specialists, where this was coming from. And the other thing is whether we could expand our ideas of diseases a little bit when we're talking about epidemics and plagues and things like that. Again, the Buddhist texts talk about famine a lot. And since the result is the same, mass death that is happening in households, I'm wondering how important the etiology would always have been if the result is the same. So that's all.
Yeah, I think let's keep it going and maybe answers will come up.
It's a very interesting point.
Yeah.
You talk about the Buddhist thought about health, society, etc. There, the emphasis is on the middle path. And that middle path is extremely significant. In fact, in my paper, I did try to draw upon how there are 4 pillars of Buddhism, 4 pillars of Ayurveda, and how, they have tried to look after. And it is Buddhism, the beauty of Buddhism is it takes care of a larger section, the whole society. It's not individualistic. Unlike the Upanishad or other Sanatani texts, where you have individuals looking for moksha, for deliverance. In Buddhist texts, in Jataka stories, you have an entirely different picture where the whole society is taken into account. So you have rightly pointed this is very good. And preventive care in terms of individual and in terms of society are different.
Mhm.
Preventive care for us had been, when purity, concept of purity, so early morning, which is limited more to the upper caste. A Brahmin would take bath 4 times, clean yourself 4 times. You will take bath in the morning, in the evening, before the archana, before the religious practices. At societal level, this was not happening. Societal level, most of the travelers' accounts which we see in 17th, 18th century, they talk about that the sanitary conditions are abysmal. They talk about, people go take bath in the same pond or tank, and they will have their animals also clean, clothes being clean. They would even relieve themselves on the pond, and all kinds of things. So far as this, at the societal level, sanitary conditions are abysmal. In fact, in my childhood, I have myself seen it. I have myself done it numerous times, 1,000 times. But but I didn't. I was not scared of. Nobody told me. Everybody was doing the same, and it was so very natural to us. To be insanitary was natural to me, to us. Now things have changed. I'm very happy when I'm not happy with this government on many other counts, but Swachh Bharat I loved. Why not have a toilet? What is wrong in it? I'm told it was done all with US aid, jo ab band ho gaya. Now they cannot do anymore. But but Swachh Bharat, this toilet program, is crucial. And look at the cultural aspect. There was a movie which came, some Prem Katha, toilet Prem Katha or something, which I like. Gee, I like that. In fact, in my house, I know, because there is a Tulsi Chora, so the toilet has to be a furlong dur, away. And it was very difficult to go there. So we will relieve ourselves whichever the closer nala was found. And it was so natural. My point which I am making is Indian society last 3 centuries have taken to, even pre-colonial time, probably, which the text would tell me more, my senior medieval scholars can tell me better, that we idolized insanitary condition. We took it as very natural. And this is in 19th century. Everybody, all the European administrators, they are abusing us. Nothing we can do about public health. These are like this. Maximum they would do is to take the tikadar to give the smallpox inoculation. Later, plague, cholera vaccination. In that also, there was so much of resistance.
Yeah.
There were riots. People were killed in Pune, and you know it. And even our great leaders, they spoke against it. Tilak in Pune, he spoke against vaccination. There was such a complex situation, a complex society at one end. This was my point I made. Complex society at one end, and very simple society at another end, when everything is natural. There are two Indias existing, two societies existing. One very natural, everything is fine, and we are a happy lot. Second, the complexities, and a foreign rule comes and tells us, look how complex it is. In fact, they are making us realize, and this is what nationalism is. When we realize this, we retaliate. No, you are doing this. But the truth is, we live in different worlds at the same time. An average individual, Indian individual, even now, lives in 2-3 worlds at the same time. So, coordination, and therefore, to think of health, which is crucial, what is most important is probably rouse the consciousness. Prevention would begin from the self himself. That consciousness. I was not conscious when I was doing all insanitary things. But after a couple of years, it grew up. Then it was stopped. I knew, no, this is not good. Flush कहाँ था पहले? कहाँ toilet था यार? I've
Okay.
written it in my Trishanku Nation. The very first page, second page of the chapter, I wrote that only two things I still remember of 1950s. One was a lady carrying the morning refuse on her head, and nobody would allow her to come near. And it was stinking. But as a child, I was absolutely worried of what is happening. Why can't we have a substitute? I didn't have any, but the smell is still in my nostril. Is still, the lady's figure is still there with such a thing carrying over her head. What an inhuman. But anyway, this
Let's maybe have some more voices in the conversation.
And second thing was another lady who brought milk. She would sit with my grandma and had chat. A milk carrier was acceptable in home, but not that refuse carrier. So it is different worlds. Thank you.
Thank you very much. Yeah.
Sorry, Vishal. I have the problems with your formulations. I thought there's a Orientalist essentialism to it. There are multiple ways of living in India, and all of them are entitled to their authentic existence. And I don't think we have the right to judge any of those forms of lives within those teleological frames of reference. I also don't think that the argument that you have a version of preventive care that is centered on individual body, and you do not have a version of preventive care that is centered on the aspirations of the community. There is actually no idea of a self outside community in the pre-colonial period. So when you talk of initiatives of preventive care centered on the body, they are actually initiatives that center on the community. Sorry.
Yes. Amrita and then Irwan. Go ahead, Amrita.
Thank you so much. My video camera is not working, so I'll just keep the camera off and go with the audio. I was thinking of through all the papers, there was a resonance around sites. There's so many sites that have emerged from all the discussions, be it household, be it court, be it like pub, like on the move, open spaces, toilets, hammams. There's so many hospitals. There are a lot of spaces that have kind of emerged as different sites of bringing healthcare, preventive care together in the conversation. I was thinking about prison, um, like modes of punishment in the early modern period. The like mutilation, suffocating, also putting them in closed chambers. This is also a form of infliction that Joita was talking about. Even if it's not like it can be self-infliction as well, but also infliction by the state. So this kind of methods of this also brings in body and punishment and body inflictions in the conversation. I think that can be a very interesting point that we can think through prison and punishment in the early modern period and how body was becoming a site of a lot of inflictions.
Thank you. Yes.
Yeah, excellent. Thank you. It was a really rich conference indeed. We were addressing, different parts of the world, but also we addressed different elements, starting with fire. Then we talked about, earth, water, so on and so forth. And also, I think we touched to the different senses, the sight, smell, touching, or tasting. I think that was the fifth sense that was really sad, I guess, in the last 3 days that we didn't touch at all, which is actually hearing. So I guess none of us actually talked about hearing. And this is interesting, especially because some of us were talking about air as well. And hearing, I think, is actually directly related to air in the sense that what we hear is, in fact, vibrations of the air, right? So yeah, looking at our papers and our discussions about prophylactics, I was wondering how would our kind of evaluations and analysis would be enriched if you were kind of paying attention to sounds as well. That would be, I guess, my question. Thank you.
I was actually thinking about you, Aydoğan, in that respect when Hina asked her question, because Aydoğan has a fantastic, well, a lot of knowledge, and also gave us a paper about oral transmission of medical and prophetic texts, which he's been mapping, and I think that's just another way of it. But I also thought about sound when we talk about fireworks, and there are other, there are other elements. But you're right that it was very implicit in the in the discussion. Are there other? Yes, please go ahead.
So, just to what you said, just as a follow-up to what he said, I think when we were talking about music in the aristocratic households as one of the preventative practices, I think, that was when the hearing part of it could have been brought into this thing. And probably it was not very clear, but as we emphasize in the paper that, music has therapeutic functions, and many people who had certain kinds of ailments were sort of made to hear various different kinds of soothing music. Also, like Dr. Chattopadhyay was mentioning earlier, that when we were talking about various spaces and all that, so when one thinks about the households, because that was the thing that we worked on, so situatedness of the health and the preventative practices, so that is something which is very important. And I think in that sense, the households of the nobles, they become very important, because if you look at health and preventative practices from the point of view of history of the emotions that Professor Geltner just pointed out. So I think households are one of the spaces where one can problematize these kinds of emotions. One can problematize the history of care, the history of grief, the history of stress, sadness, happiness, joy. And then apart from that, you have these various kinds of relationships like friendship, political negotiations, conjugality, domesticity. So I think that, the sphere of the household, because even before one starts thinking in terms of public health, because there's a saying which goes on, if you have a healthy body, then only you can contribute to the health of the society, right? So one starts focusing on one's health, for example, and then once extends one's caregiving practices to the family, to friends, to community, and then to the society in general. So I think it's if one looks at the household, then one can sort of problematize all these things, these emotions, these kinds of varied relationships. And also, I think this is one area where you can deconstruct these kinds of boundaries between the elite and the liminals, something that you were talking about. Because people who were involved in these aristocratic households, and when you talk about aristocratic households, you are just not talking about the aristocrats per se, right? So, like we made this point that, they are differentiated on the basis of various classifications of communities. So, say for instance, of course, there are the nobles, but also there are the slaves, there are the attendants, there are the female concubines, for instance. So you have a varied range of communities, social classes, which are residing within that entire complex thing. And I think there's a huge similarity between households in the context of Europe and in the South Asian context, especially between the 16th to the 18th century. And that is something where you can also bring in not only the roles of the liminals in looking at health and preventative care, but also from the view of gender, women, gender, sexuality. What roles were these kinds of communities, playing? So for a kind of a wholesome understanding. So, and also to situate healthcare practices and this healthscape.
Perfect. That's actually a perfect note on which to seg to a final word. Now we will end a minute late, but that would be it. To say, and also in response to Jarita's question, it really piggybacks onto what you just said, that I think that it's less productive to think, I think that we initially talked about preventative health as a response to historiography's focus on curative. But I think it is much, and that's okay, that's legitimate, it's a correction, it's an intervention, but I think it is more productive and more open and more subtle to think about environments and how we intervene in environments. They can be households, they could be colleges, they could be cemeteries. It doesn't really matter right now. And there, all of those binaries play out in the way that undermine their binarity, as it were. So I'm really inspired by much of what has been going on, well, in our group in general and in this conference in particular, to think about environmental, and certainly within a Galenic framework and a Vedic framework, there are many reasons to think about planetary health, which is supposedly a new thing, but we all know it is not. Planets are considered something that impact everyone's health, so they impact at the planetary level. No reason to shy away from that. We don't need big, sophisticated equipment. And those are, again, some of the very important things that I am walking away after 3 days with, and I hope it's leaving some taste for more. Certainly for me, I hope for friends in Melbourne and in Tuscany as well. I am immensely grateful to you for organizing. It's been a real pleasure these last 3 days. And I'm not just talking about the food. I'm especially talking about the company and being able to meet old friends and new friends. And I'm just sorry that not everyone could be here in person, but hopefully we will make amends on that front as well as soon as we can. I'm very grateful for everyone's papers and efforts and participation and formal and informal communication around the tea and the food, and all of our micro and macro organizers for all of their hard work. I'm really, really thankful for everything. So please join me for one last round of applause for all of those people who made their. Thank you so much. And we're off, right? We are done. We are done. Thank you. Yeah.
Thank you very much, Oxford.